Hello, my name is Christina and I'm an occupational therapy student at Texas Women's University. Today I'm going to be conducting a shoulder examination and it's primarily going to consist of three parts. The first is going to be inspection of the shoulder, the second is going to be palpation, and lastly I'm going to conduct a range of motion examination. I will conduct specific shoulder pathology assessments later on throughout this video and I'll explain that in more detail later. So the first thing I'm going to do is start off with the inspection portion of this examination. Upon inspecting the shoulder, the first thing you want to look out for is any scars. Any scars can be indicative of any past surgeries that the examinee may have had. The next thing that you want to look out for is any swelling. Swelling may be difficult to notice because the GH joint is so deep. But if swelling were to occur, it would occur on the anterior aspect right here of the glenohumeral joint, and then at some times it may occur at the acromioclavicular joint as well as the sternoclavicular joint. You may also look at these two joints as well as the glenohumeral joint for any redness of the shoulder. And the next thing we want to look out for is muscle atrophy. Muscle atrophy can occur primarily at the deltoid muscles around here and as well as the rotator cuff muscles, which include the supraspinatus, the infraspinatus, and the teres minor. When atrophy occurs at the deltoid muscle, the shoulder would have an appearance that's very squared, whereas on Maria, the shoulder looks rounded like so. This is indication of a normal shoulder. Okay. The next thing we want to look out for when examining the shoulder for the inspection part, we just want to make sure that there isn't any scapular winging. Scapular winging would most likely occur here at the medial border of the scapula. So now we're going to be conducting the shoulder palpation examination. First, we want to start here at the sternum. So we'll just continue to palpate going proximal. And if we go just slightly lateral, we'll feel the sternoclavicular joint. So we need to just feel for any tenderness or pain. Then we continue to palpate along the clavicle. The medial end of the clavicle here is more of the convex, whereas the lateral end of the clavicle over here is more concave. Just below, right here on the clavicle, is the coracoid process of the scapula. This typically does have some tenderness. As we go back up to the clavicle, and we continue to go lateral, we'll feel the acromioclavicular joint right here. We also make sure that we just palpate that to see if there's any tenderness or pain at this particular joint. Once we get to the acromioclavicular joint, we can come down and just palpate on the humerus. As you can see here, this is the proximal part of the humerus, and then we just feel distally. Okay. When we come back up, the rounded edge here is the acromion, which is very bony, and then we'll continue to go back here on the spine of the scapula. Okay. Then, once we get to this medial corner, we'll just continue to palpate down and just to see if we have normal feel of the border of the scapula, as well as any pain or tenderness. Once we have felt the bony prominences on this scapula, then we can continue to palpate the rotator cuff muscles. Here's the supraspinatus. Then you have the infraspinatus, and then you have the teres minor here. Rotator cuff muscles, as we know, stabilize the glenohumeral joint. Okay. The last and important thing that we also need to palpate during a palpation examination with a client is the axilla. So when palpating the axilla, you always want to palpate the medial part of the axilla as well as the lateral part of the axilla. And this concludes our palpation and inspection examinations. Now we will begin the range of motion testing. But before we begin, we first want to look at the movement of the glenohumeral joint and the scapula. As Maria abducts her arms, the first 120 degrees of movement is due to the glenohumeral joint. The last 60 degrees is due to the scapula sliding on the thoracic cage. This completes the 180-degree arc of motion. Now we will look at the anterior aspect of Maria. When we complete the range of motion testing, there's two main things we want to look for during this formal range of motion test. First, we want to look at the smoothness of the movement as well as the extent of the movement. The first range of motion test is abduction. If there is any pain in the first 120 degrees of arc of motion, this is due primarily to impingement or rotator cuff pathology. If there is any pain in the last 60 degrees of abduction, this may be due to acromioclavicular joint problems. Okay. The next test that we will complete is external rotation. This is to see if Maria can lift her hands behind her head. This is extremely important for functional tasks for grooming, such as combing your hair and brushing your teeth. The next test we will do is the scarf test. Basically, Maria will reach over and grab the opposite shoulder. This movement is also important for functional tasks such as dressing, grooming, and bathing. If there is any pain, this may be due to the acromioclavicular joint. The next view that we'll look at is the lateral view. We will have Maria lift her arms above her head for shoulder flexion. As you can see, that's the 180-degree arc of motion. Now Maria will do shoulder extension. She will bring her arms all the way down and then extend them back. Now Maria will turn and we'll look at the posterior aspect. Maria will do internal rotation and adduction. So she will do this by reaching towards the inner part of her back to reach towards the scapula. This right here is important for things like scratching your back. The next test is where Maria will be doing a push-up on the wall. The push-up on the wall test is pretty much for winging of the scapula. The next test that we will be doing for range of motion is external rotation, and we will look at the anterior aspect of Maria. She will bring her arms to her elbows to 90 degrees and then externally rotate her arms outward. Then she will continue to do the same thing just so we can look at the internal rotation and bring them inward. This concludes our range of motion test. So now we will be conducting the passive range of motion test. The two main things that you want to look for are crepitus and to feel the end feel. First, I'm going to start by placing my hand on the acromion, right, like this, and then I'm going to abduct her arm like so. I'm going to externally rotate it, and then I'm going to internally rotate it. And like I said, the things that we're looking for are crepitus and to feel the end feel. Okay. The next thing we're going to do is a few assessments for the glenohumeral joint. The glenohumeral joint is a ball and socket joint, and it's basically held together by the muscles of the rotator cuff. The first test that we're going to do is a near test. The client will first flex the shoulder all the way up and then internally rotate their arm. If there is pain here, this is indicative of an impingement. The next test we're going to do is the Hawkins maneuver. Here, the client will keep their arm flexed at 90 degrees and then flex her elbow at 90 degrees. The examiner will apply some pressure here. And if there is any pain, this is a positive sign for the Hawkins maneuver. So now we're going to continue on to test some of the rotator cuff muscles. The first test that we're going to do is for the supraspinatus. This test is called the resisted isometric abduction test. The elbows are flexed at 90 degrees and then abducted 15 degrees. The examiner will come around and add resistance while the client attempts to resist my resistance. The next test for the supraspinatus is called the empty can test. The patient will shoulder flex their arms to 90 degrees and then internally rotate the arm. The examiner will then add resistance to the humerus, and once again, if there is pain while the resistance is added, this is indicative of a supraspinatus problem. Now we're going to continue on to test the infraspinatus and teres minor muscles of the rotator cuff. The first test is called the resisted isometric external rotation test. The patient will flex their elbows at 90 degrees and then externally rotate their arms. Make sure that the arms are close to the side, just like so, and that the patient does not move during the test. The examiner will come around and then add resistance to the client as the client tries to resist my pressure. The next test we're going to talk about is for the subscapularis. This resisted isometric internal rotation range of motion test starts off by the patient flexing their arms at 90 degrees and having them internally rotate their arms. Once again, you want to make sure that their arms are close to their sides, and the examiner will then attempt to bring out the arms like so, while the patient resists my pressure. And lastly, we're going to do the subscapular lift-off test. For this test, the patient will stand and reach towards the back of their back. Then the client will lift their arm off of their back. If the client cannot do this, or when resistance is added and there is pain, this is indicative of subscapularis problems. Go ahead and sit down. Now, this concludes our first section of the assessments for rotator cuff muscles. So now I'm going to be conducting a few assessments for the biceps. First, I'm going to place my hand on the acromion right here and then just drop it down just a bit. Here, I'm going to make sure that she flexes her arm and then externally rotates it. As she does this, I can actually feel the biceps tendon right here. Okay. So the first test we're going to do for the biceps is called the Jorgensen's test. I'm going to start with my thumb on the biceps tendon like so. I'm going to have the client flex her elbow at 90 degrees, and then I'm going to have them supinate their arm. I'm going to attempt to pronate their arm while the client resists, and at the same time palpate right here where the biceps tendon passes through. If there is pain if they cannot resist, or if there's pain here, then this is a positive sign for Jorgensen's test. The next test I'm going to do is the Speeds test. Both of the arms are flexed at 90 degrees and they're supinated. The examiner will come around and then add resistance to each of the humeruses like that. If there is any pain on the anterior aspect, this is indicative of bicep positive sign for Speeds test and bicep tendon problems. The next test that I'm going to do is for the acromioclavicular joint. And this is especially important because it's a main cause of osteoarthritis of the shoulder and various shoulder injuries. So the first test that we're going to do for the acromioclavicular joint is called the scarf test. The patient is going to reach over to their side as far as it can go, and the examiner is going to apply some resistance here. If there is any pain around the acromion, this will indicate a positive scarf test. Another way that the scarf test can actually be tested is for the patient to bring their arm behind their back like so. And then the examiner will also apply resistance here, and if there is pain, it's a positive for acromioclavicular joint problems. The next test I'm going to be doing is for GH joint stability or glenohumeral joint stability. This test is basically done by grabbing the humerus like so and then moving it anterior and then posterior. Anterior and posterior. Now we're going to be testing the myotomes. First, we're going to check the C5 myotome. Here, the patient will have their shoulder flexed, abducted, and elbow flexion like so. Now, for the C6 myotome, there's going to be elbow flexion and wrist extension. The next myotome is C7, and there's going to be internal rotation and wrist flexion. The next myotome is C8, and there's going to be some elbow flexion as well as flexion of the MCPs. And lastly, to look at the T1 myotome, there's going to be elbow flexion and finger abduction. This concludes the myotome testing. Now we're going to look at the dermatomes for the upper extremity. The C5 is going to go from on the lateral aspect here of the arm. The C6 is going to be right here at the tip of the thumb. The C7 is going to be at the tip of the middle finger. The C8 is going to be the tip of the little finger. And the T1 is going to be on the medial aspect of the arm. This concludes the bicep assessments as well as the myotome and dermatomes. Thank you for watching.